Professor Watkins, can you tell us about yourself?
So I'm a professor of medicine at the University of Oxford. I'm a cardiologist and I'm a researcher. And all of my clinical practice and my research has always been focused on inherited heart muscle disease, genetic cardiomyopathies. So I see patients with these conditions and I have worked in the research program to understand the genetic basis of those conditions. And we've now got to the point through the CureHeart program of aiming to create genetic therapies.
Could you describe the CureHeart program?
So the CureHeart program is a research program. It's based in universities here in the UK and in the US that is aiming to create genetic therapies for cardiomyopathy. We are funded by the British Heart Foundation, the UK heart patient charity.
What is a gene and what is genetic therapy?
So what is a gene? A gene is really our blueprint that we have in all the cells of the body that tells that cell what are the building blocks it needs to assemble to make a protein. And it's the proteins that come together to do the work of the cell. And for cardiomyopathy, that's really what we think of as the molecular motor that drives contraction within the heart. By and large, patients who've got a cardiomyopathy of the genetic variety will have one single fault in the gene, one single spelling mistake, if you like, that they will have inherited from one or other of their parents. That's the usual situation. And that means in their heart, they'll have one healthy copy and one faulty copy. And the faulty copy is responsible for the condition. We know there are two different ways, two different broad categories of genetic fault that can cause a disease, and they do that by different mechanisms that will need different therapies. Sometimes the situation is that the faulty gene makes a copy of the protein, that's the building block of the cell that makes up the heart, makes a copy that's faulty. So in the cell, you have a healthy copy and a faulty copy, and the faulty copy gets inside the machinery. We think of it as the molecular motor, and it stops it working. So in that situation, to fix the problem, we have to either correct the faulty copy or switch it off or silence it. We have to remove the faulty product of the gene. And that has a certain set of technologies that we can develop. There is a different situation that we see in other genes for other patients with cardiomyopathy, and there the fault in the gene makes that gene copy not active at all. So they have one healthy copy and the other one is not doing anything. And then the problem is not enough of the protein that's needed to make the normal function in the heart. So the strategy there has to be to help the cell to make more of a healthy copy, and that requires different technologies and different approaches to treatment.
Can you explain more about the genetic therapies you're developing?
For both of these situations, the faulty one we have to turn off or the missing one we have to replace, we are taking some approaches that are what I would describe as reversible. We would create a genetic medicine that we might, for example, administer by injection under the skin or into the arm that would do this job of switching off a gene or turning on another one for a period of time, maybe months, that would then need to be repeated. And these are medicines that are a type of medicine that already exists for other diseases. So we know a little bit more about how to make them, how to make sure they're safe. They're probably the type of medicines that we might first be able to create for patients. What you'd really like to do is create a medicine that you could deliver once that would do this job of turning off the faulty gene, or perhaps turning up the missing one, and do it in a way that was lasting, so that you would do it once and it would last forever. And these are techniques we call genetic editing. And these approaches are not yet licensed as medicines for patients. And so the journey to bring them to the point that we know they're effective and know they're safer is a longer one.
How could a genetic therapy be delivered to the heart of the person being treated?
So most of the approaches that we're trying to make would be introduced into a patient's body, not as tablets, but as injections, and they would spread throughout the body, but we would design them that they only worked in the heart. That's where they would find the gene that they needed to operate on in the heart. And an important point for me to make is that we wouldn't be changing the genes that we pass on to next generations. We would just be changing the genes that are actually in the heart. How we get the medicine, the genetic medicine, into the heart very much depends on which of these approaches that we are talking about, whether it's one of the reversible ones or whether it's an attempt to change that gene forever in the cells of the heart. The reversible approaches, which are the ones that I think are nearest to development and would be the ones we might first hope to test in patients, are generally administered by a simple injection, perhaps under the skin or possibly into the veins of the patient, and that has to be repeated. We would hope it wouldn't have to be very often, but it might be a few times a year, for example. And then they go into the bloodstream, they spread throughout the body, but they find, because genes, this DNA sequence is very precise, they find the precise gene that they align up with in the heart and they do their work there. If we think about the editing approaches, where we make permanent changes to the genes in the heart, at the moment we would need some sort of vehicle that helps carry that medicine from the site at which we inject it in the arm into the heart. And that's quite a challenge, and we haven't solved all the issues yet. That's why it's a research program. Sometimes we use an inactivated virus. Inactivated viruses are good at getting into the heart, certain viruses are. We inactivate them to make them safe. We put our genetic medicine inside and they carry it there for us. But they can cause inflammation, and that's one of the side effects we have to be aware of. There are also approaches that are in development but not yet used in patients that wrap up the genetic medicine in a little package that can go through the bloodstream and be delivered to the heart. But that remains really important work that CureHeart has to take forward in coming years.
Once a therapy has been developed and a way of delivering it to the heart established, what are the next steps?
The next steps are really all about showing that this is safe and effective in a patient. We can already do this in the laboratory. We can cure cardiomyopathy in cells that we derive from human samples and in mouse models. So this is all about safety. For the reversible injections that are of a type that are licensed for other indications, we know quite a lot about what to look for. I think that work can go quite quickly. I think it's reasonable to think that we would be doing trials of these medicines in patients in, say, 3 to 5 years. For the editing therapies, we haven't yet really solved all of the delivery hurdles. I think it's 5 years plus. But sometimes these things go quicker. There's a huge amount of medical research in this area.
How would you test the treatment in patients?
So the first time we would test a new treatment, we'd do it in a small number of patients who volunteered to take part in that research. And we do it in a small number to be absolutely sure that everything goes to plan and is safe. And they would have to be patients that had a particular gene and a particular cardiomyopathy that was suitable for that first medicine that we were ready to test.
Are there any risks or disadvantages to genetic therapies?
There certainly are risks that we are very mindful of, and there may be risks that we don't yet fully know about because this is a new type of medicine. I think they're balanced by the need. We have very substantial unmet needs, but we have to be very, very careful. So some of the risks we can think about are some of the known ones. We want our genetic medicines to go to the heart, but we know that they will also go to other organs, particularly the organs that remove foreign objects from the body, the kidney and the liver. So we'd have to look very closely to make sure that the medicine don't cause problems with the kidney or the liver. Some of the agents that we would use to do these therapies can cause a reaction, an inflammation within the body. Sometimes that will be like a flu-like symptoms, but it can be a serious inflammation. If we're thinking about the instances where we have to use an inactivated virus, sometimes we have to use an immunosuppressant drug, a drug that dampens down the immune system to cover a period of a few days while that virus is used to deliver genetic medicine. We also know that our genetic medicine, although we design it to be 100% targeted to the gene change that we want to target, could potentially affect other genes. For a reversible treatment, that's less of a concern, because if we see effects we don't want, then we can withdraw the treatment. But for editing, that could be a permanent change, and that's why we won't get to editing until we're really, really sure that we're only targeting the gene that we want to target.
Which patients with cardiomyopathy might be suitable for genetic therapy?
The approaches that we're developing could be applied for any cardiomyopathy. So they could work for patients with hypertrophic cardiomyopathy or dilated or even arrhythmogenic or restrictive. But we're only able to fix a single underlying gene change. So they'll only be applicable to patients and family members who've had a gene test that yields a positive result that identifies a pathogenic variant that we know causes the cardiomyopathy. And for patients whose gene test is negative, where there isn't a single gene in the state that we can fix, these treatments won't be available. But we do hope that patients with that type of disease tend to have a milder illness and are rather less likely to pass it on to their relatives. But very much our focus is where there is a known variant that we can aim to correct. The nature of the work that we do means that we will develop a medicine that will be specific for a particular gene. And that means that if you have a particular cardiomyopathy and this is the gene that causes your cardiomyopathy, that medicine could work for you. And that might be the one that we trial first. If that's shown to work, we or others would then have to develop another medicine for each successive gene. And this means there will be more testing and more time will go by before these therapies become available as widely as you really want them to be.
Among patients with an identified genetic cause for cardiomyopathy, is there a specific group that genetic therapy might be more suitable for?
In terms of picking the right patient, the right treatment, we've got to be very mindful of what the patient's looking for, but also what the doctor's worried about and what the treatment might help with. To me, this is very much about progression. Cardiomyopathies have this tendency to get more severe, more troublesome through life. And if we had a therapy that we thought could prevent progression or stabilize it, possibly even reverse it, we would be thinking as physicians, when's the right time to deploy that therapy? And the patient, I think, would be thinking from the impact on their lifestyle and what they wanted to do and what they wanted the medicine to do. If we had a therapy that we knew was effective and knew was safe, our instinct would be to recommend treating earlier in the natural history and the development of a cardiomyopathy. We know from animal model work that it's easier to stop cardiomyopathy from ever developing than reversing already damage done in the heart. But we'd also be very mindful that certain types of progression are medically difficult to deal with at the moment. So some patients with cardiomyopathy progress towards heart failure. We don't have very good remedies. That would be exactly the sort of circumstance where you would want to deploy the genetic therapy to try to prevent that person's heart getting worse enough that they might, for example, need a heart transplant. And in that instance, you would be able to use a therapy, even one that had an associated level of risk, if you thought there was a good chance you could stabilize that heart. And another critically important effort is we need to be sure that we understand what the patient's perspective is. What do they hope for that these therapies could deliver? What do they worry about in terms of side effects or risks? so that we design therapies that patients want. There's no point us making a therapy that could work if it doesn't meet the requirements of the patient community.
Are there any technical considerations in terms of which patients could have genetic therapy?
There are some that we can spot now, and I'm sure there will be other considerations that we don't yet know about. We're still learning as we go. One thing that's on my mind relates to the genetic therapies that we would need to deliver by using an inactivated virus. We know that some patients have been exposed to a relative, a cousin of that virus during their normal lives, and they've got antibodies. And that would mean that they would not be eligible for that treatment. And further, if we had a patient who went into a trial using one of those viruses, we know that they would make antibodies, and that would mean they couldn't have a second or further treatment of that therapy or another one that needed that virus to deliver the therapy. So that raises quite complicated issues because some patients wouldn't be eligible from the start, and others would only be eligible one time. And that's a challenge in a program that's always developing better and better therapies.